Good afternoon, everybody. I am Luba Wartikowski, and welcome to the opening session of 2008 Demystifying Medicine. And my husband, Irvin Arias, has an upper respiratory infection, so much for infections. And so he is not here today, so you got me to introduce the course as well as the speakers. This course seeks to bridge basic sciences in human health. The goal is to excite both basic and clinical sciences to exciting, new, challenging questions in each disease entity that we discuss. At the NIH, the course is broadcasted live, and so many people are probably sitting with their computer and watching it live. And within a couple of days, it will become available by YouTube and by NIH archive, on video archive. And it is being used in 18 countries around the world and more than 24 American universities. So it's a widely used course and widely viewed. We would like to ask you to be sure you sign your name and attendance in a little black book that is being passed around. It's important for us to know which institutes participate, and also if you attend more than half of the sessions and also pass the final exam, which I assure you is not very difficult, you will get a Demystifying Medicine certificate from NIH. So let us focus on today's topic, which is being circulated. This is opening session for Demystifying Medicine. And it is new viral diseases, universal vaccines, and removing infectious agents from the blood supply. The traditional response to infectious diseases has been to obtain epidemiologic data, identify the organisms, seek pharmacological treatment, educate the public, develop vaccines, and so on. Eventually, to move to the next infectious diseases crisis. This has been the route that has been spectacularly successful in the past. In many recent infections, including SARS, Ebola, HIV, West Nile virus, as well as including all of this bacterial as well as parasitic drug-resistant diseases. This time-consuming process has been produced very spectacular results. In most cases, it is based on a principle that first we obtain epidemiological data. That means the disease occurs first. And from the epidemiology, we move to developing vaccines, drugs, etc. If the response is rapid, then the success is assured. The genomic immunologic era of today has prompted inquiry to novel techniques for rapid detection of infectious diseases before they become an epidemic, worldwide public measures for education, for detection and prevention, and considering challenging questions such as developing universal vaccine and also removing all nucleic acid-based material from blood supply. Our first speaker today is Dr. Anthony Fauci, and he will discuss the perpetual challenges of infectious diseases. After graduating from Cornell University School of Medicine and completing internship and residency training, he came to NIH in 1968 as a clinical associate in NIAID Laboratory of Clinical Investigation. In 1980, he was appointed as a Chief of Laboratory Immunogenetics, a title that he holds today. In 1984, he became the director of NIAID. Dr. Fauci serves as a key advisor to the White House and the Department of Human and Health Services on global HIV/AIDS and an initiative to bolster medical and public preparedness against emerging diseases, infectious diseases threat such as pandemic influenza, Ebola, and others. For his research and accomplishment and leadership role, he has been receiving almost all major awards, including National Medal of Science, Lasker Award, and Gardner Award. He's a member of National Academy of Sciences and received over 30 honorary degrees. When my husband specifically asked me to comment that Dr. Fauci has not lost his youthful appearance even almost 35 years after he has been the director of NIAID, and has not aged in energy and accomplishment. So we will be very glad to hear him today. Our second distinguished speaker today is Robert Allison, Acting Chief of Infectious Diseases, Department of Transfusion Medicine at the NIH Clinical Center. Dr. Allison earned his MD degree in Florida State University College of Medicine and MPH in Infectious Diseases and Epidemiology at the University of South Florida. After training in preventive medicine and public health at Johns Hopkins, he was appointed for clinical research fellow between 2006 and 2008 at the NIH Department of Transfusion Medicine under Dr. Harvey Alter, with focus on prevention, on transfusion-transmitted infection, and on epidemiology, natural history, and pathogenesis of hepatitis C. Dr. Allen has been actively involved in surveillance and prevention of communicable diseases and non-communicable diseases in the US and globally in Africa, Asia, and has been an active duty US Naval medical officer. Dr. Allison rejoined Department of Transfusion Medicine 2016 as Deputy Chief in Clinical Studies under Dr. Alter and was appointed Active Chief of the Infectious Diseases section in 2017. His section includes the Transfusion-Transmitted Viruses Laboratory, which performs molecular diagnostic testing for HBV, HCV, HIV, and other viruses in support to NIH investigators. He manages a prospective donor-linked vigilance study on transfusion-transmitted infections and is involved in developing a pathogen chip for simultaneous molecular detection for up to 30 infectious transmitted bacteria, parasites, and viruses. Dr. Allison's work has been widely recognized, and he is recipient of the Cass Award from the Infectious Diseases Society of America. So please join me in welcoming our first speaker, Dr. Anthony Fauci.
Thank you very much for that introduction. It's a pleasure to be here with you this evening. As you probably saw when he switched the slides, I'm not going to talk about the title that was originally put up. I'm going to talk about emerging infectious diseases. And I thought, I kept on emailing Wynn. I said, Wynn, that's the wrong title. And he kept on saying, okay, don't worry about it. We'll change it. I said, it's the wrong title. Don't worry about it. We'll change it. So in any event, the reason I decided to do that is that it's just something in real time that I hope you will be interested in some respects, learn from, but also maybe be a little bit amused by, is that since we're a Washington, D.C. audience in the Washington, D.C. area, I want to talk about emerging infectious diseases in the context of something that happened in real time here in the Washington, D.C. area just over the past year. And it's a true story, and I'm going to tell you a story as I talk to you about the global health and the science, because it's a true story. So as we know, President Trump was elected in November of 2016, and in the interval between his election and his inauguration in January, he had appointed, in the sense of named, his entire cabinet, who had not yet been confirmed by the Senate. But everybody knew who they were: Mattson, Tillerson, all the others. So Dennis McDonough, who I had become quite good friends with during the Obama administration, who was the chief of staff to President Obama, in a spirit of collegiality, decided that he would have a meeting at the White House, and the purpose of the meeting would be to alert the now soon-to-be leadership of the Trump administration about the dangers and unexpected events that tend to occur usually in the first year of your administration. So in that interval between November and January, they brought them together and we had what's called a tabletop exercise. And it was actually written up in the publication The Hill on January 13th, which note is before the actual inauguration. And what it was is the White House, still the White House being the Obama White House, held a disaster response exercise with Trump officials. And the scenario was, we're going to say there are at least four possibilities. One is a terror attack with bombs and bullets. The other is another Hurricane Sandy. The other is a cyber attack. And the other is a outbreak of a deadly infectious disease. So if you just take a deep breath and think about that, we've already had 3 of those. We've had a terror attack with bombs and bullets in Las Vegas. We've had a cyber attack against our own elective process. And we've had multiple hurricanes in the Caribbean and within our Caribbean coast and the Gulf Coast. So my job, together with Secretary Burwell and Tom Frieden, was to talk a little bit about the kinds of possibilities that we might have with regard to infectious diseases. And that's what I want to talk to you about, of some of the things that I was able to formally present, and then in the sidebars when we were talking around at the breaks, the things that I brought up. So here's the way I started it off. I said that I've had the privilege. This is a picture when I was first named as the director of NIAID. Some of you don't know, I was named when I was 14 years old. I was the youngest director in history. I really actually was the youngest director in history, but I was really 14 years old at the time. And I've had the privilege of working over the years with 5 presidents, each of which had the same issue of unexpected things that I was trying to say there are lessons to be learned. So I'll tell you a little bit about the lessons. So one of the things that I did learn is that you have to always explain things to congressional committees. In fact, I just came back from talking about flu to the House and Energy Subcommittee of the House of Representatives, who are obviously concerned about influenza. But one of the things that I mentioned to them is that the importance of infectious diseases. So I started testifying in the year that I was appointed, and I have an interesting indoor record, which, I don't know, I guess you could either be proud of or sort of scratch your head about, that I've testified before Congress more than anybody else in history. And you say, oh, you're crazy. It's the truth. And the reason it's the truth is because I've been doing it multiple times a year for the last 33 and a half years that I've been the director. And every time I've testified, it had to do with an emerging infectious disease. From the many times that I testified about HIV to the dozens of times about Ebola and Zika and all those things. So that's what I'm going to tell you about. So the first time I testified before the Congress, I had one of our graphics people draw this map of the world. And the point I was trying to make was that we are going to see a lot of infectious diseases. Some of them will be brand new, and some of them will be re-emerging. And the first one that I put on the chart was HIV, because remember, I started off in the early 1980s. I became director in 1984, and that was in the very early years of the AIDS epidemic when we didn't even know it was HIV. And I showed this map, as I've told an audience like this so many times, every single time I talk to the Congress, and every chance I get to show a poster or a slide, I show this slide. And the reason I show it, they never ever get tired of it, because every year I add 1, sometimes 2, sometimes 3 new infectious diseases. So the last time I did testify before, it was this afternoon, but the last time I testified before for the budget, this is what the slide looked like. So many of these are just, inconsequential curiosities, but some of them have had profound impact. So I want to talk to you about it. So I started off by saying these are the 5 presidents that I've had the opportunity. Now, I can't, because of time, talk to you about every single time that we had a major or mini crisis. So I want to pick out some selective things that have happened to impress upon you the repetitiveness of what happens. So let's start off with Ronald Reagan.
So Ronald Reagan became president. Remember, my theme to this group was be careful in the first year or two because bad things happen. So Ronald Reagan was inaugurated in January of 1981. I was not yet the institute director. I was a laboratory chief in the intramural program, of which I still am, but I was there studying various immunological and infectious diseases. So what happened in the first year of Ronald Reagan's presidency? In June of 1981, the first 5 cases of gay men from Los Angeles were reported in the Morbidity and Mortality Weekly Report. Personally, I was in my lab, and I remember seeing it, thinking that this was a fluke. It was some sort of a drug that they had taken. I was very curious that they were all gay men, but maybe they were in a party or something and suppressed their immune system. Then something happened a month later which changed my entire medical career, if not my entire life. And that is 1 month later, 26 gay men now were reported not only from LA, but from San Francisco and from California, from New York City, who not only had pneumocystis pneumonia, but also had Kaposi sarcoma and other opportunistic infections. So I decided at that point that I was going to do something that was very unusual for a lab chief. I was in a pretty successful career, not as successful as Harvey Alter, but it was pretty successful, doing things with, hi Harvey, doing things that were pretty successful. The reason I say that is that we were talking about being here. We were probably here the longest than anybody in a long time. Anyway, it was a lot of fun. So I decided that I was going to stop what I was doing, and I was going to start bringing in, at the time, completely always all gay men with a disease that nobody understood because we didn't have any idea of what caused it, even though we were searching for it. So when I did that, my mentor, and this is the lesson for the young people in the audience, my mentors who were good mentors, one, Shelley Wolf, who's an iconic person here years ago, said to me, why are you throwing away a potentially great career by studying a disease that's not going to be around in a year or two? It's just going to go away. So I decided that I was going to publish an article as what I call my Apologia Pro Vita Sua. So I took Latin in high school and college, and every once in a while I have to let everybody know I understand Latin. So I say Apologia Pro Vita Sua, which stands for an apology or explanation for what you do with your life. That's what it means. So I wrote an article, and I submitted it to the New England Journal of Medicine, who actually turned it down because they said I was being too alarmist. So I sent it to the Annals of Internal Medicine that accepted it. I wrote it in November of '81. And what I said in that was, because we don't know the cause of this syndrome, any assumption that it was going to remain restricted to a particular segment of our society is an assumption without scientific basis. At the time I wrote this, there were 159 cases of what was called GRID. It wasn't even AIDS, of gay-related immunodeficiency then. So why am I telling you this story about presidents? Because the one lesson that we learned, and it was a painful lesson for Reagan, is that outbreaks sometimes creep up on you, and if you don't take the opportunity to use the bully pulpit of the presidency to warn that this is something we should be doing something about, we were slow in our response in the first year or so. And what happened is that he was slammed by the activists, and this is just a demonstration from ACT UP New York that some of you may remember the situations that we had with activists. Fast forward 36 and a half years, and unfortunately, my statement in the annals was quite prophetic. I wish it were not, but it was, because as we all know now, there have been about 76 million new infections, 30 million deaths, 36 million people living with HIV, 1 million deaths a year, 1.8 million new infections. Now we move on to George H.W. Bush. He also had HIV/AIDS as his major emerging infectious disease. The difference is that he had a different attitude. When he was running and thinking about running for president of the United States in 1988, he wanted to really learn about HIV. So I had been tooting the HIV horn from 1981 to 1988. So I was pretty well known as somebody who was out there vocally, even though President Reagan was not. So he asked to come to the NIH and visit with us and have me show him around. And as it turned out, he's just that kind of a person that we developed a very strong relationship, and we actually became good friends, and he was inviting me to the vice president's mansion, et cetera, et cetera. As it turns out, I learned one of the big lessons. In Washington, be nice to everybody, because you never know where they're going to wind up. And vice presidents sometimes wind up as president. And sure enough, as soon as he became president, he started to concentrate on HIV. And this is a picture of him who I invited, and he accepted immediately to come to the NIH to visit. And this is the solarium in Building 10 on the old 11th floor, where I brought together patients of mine who we used to have every couple of weeks a meeting with the patients to have them sort of express the kinds of things that were worrying them. They usually came in just with their hospital garb, but they all got dressed up, obviously, because the President of the United States was there. And here is one of our patients with the gray three-piece suit. I'm there with my white coat, and that's Barbara Bush. Now, the reason this is important is that that was the first attempt on the part of a leader to do something about it. And everybody, unfortunately, remember, this is 1988. AZT was just approved in 1987. That was the first time that we had a situation of a president really being very concerned about a disease like this. Unfortunately, everybody in that room died ultimately from HIV because we didn't have it. But in the room coming with him, another story, was someone who was on his staff who turned out to be consequential. See if you recognize this person. This is his son, George W. Bush, before he became the president of the Texas Rangers and before he became the governor of Texas. The reason I show it, because it's, again, a part of my first lesson. Be nice to everybody, because you never know where they're going to wind up. And actually, we developed a relationship back then. And the reason I'm going to tell you, because in a couple of minutes, he did something 20 years later that was extraordinary with regard to infectious diseases. Now, what about George H.W. Bush? What he did is he did take the opportunity to increase the budget. And what we saw was an exponential increase in the HIV budget, which then led, and again, another lesson, when you put resources in biomedical research in public health problems, they pay off. Because of the, look at the advances from 1981 to 2017, they are nothing short of breathtaking. I could spend the entire hour talking to you about all the advances, but one was particularly important, and that was in the arena of treatment. So this is a picture of me in 1982, in January of 1982, taking care of an AIDS patient prior to even knowing that HIV caused it. The reason I show it to you is that at that time, patients presented with advanced disease and the median survival was 8 to 15 months, which means that 50% of all of your patients would be dead in 8 to 15 months. What happened with the investment in science? We developed a whole bunch of new drugs that now, when given in combinations of sometimes one pill containing 3 drugs, has completely transformed the lives of HIV-infected individuals. So that right now, in the same place that I was telling people that we really didn't have much to do for them but give them drugs for opportunistic infections, if somebody in the mid-20s comes in with early disease and I put them on a combination of 3 drugs, I could look them in the eye and tell them that I could predict with accuracy that they likely will live an additional 53 years. So that's now one of the most important advances in biomedical research, translation to health, literally in our era. I mean, I can't think of anything as important as that. I mean, obviously there are other major breakthroughs in medicine throughout the years, but this ranks way up there. Prevention was also, now we have ways of preventing infection that are really important. Then gets Bill Clinton. And this is really an interesting story, because Clinton also had a very interesting view on health and science. He was interested in the, he was a scientific wonk. He really wanted to know a lot about the interesting little ins and outs of science. So in 1995, 1996, a new receptor, which was very common now, the CCR5 co-receptor for HIV, was discovered. And it was all over the newspapers about this new receptor. So he had heard about it. So he invited me to the Oval Office, and there I am in the Oval Office explaining to him what the mechanisms of binding of the virus to the cell. You wouldn't think you would explain that to the President of the United States, but he was actually interested in it. But he wanted an update on HIV. So as he was getting ready to walk out, and the distance was really from this podium to the door to go out into the Rose Garden for him to tell the press that he had just met with officials from NIH, the fellow here on the side, that's Harold Varmus. You can recognize him by the bald spot. Is here. Harold was the director of NIH at the time, and he had said that he was meeting with officials from the NIH, and he just wanted to talk a little bit about HIV. But in between here and there, he turned to me and he said, by the way, it's 1996. We don't have a vaccine for HIV. What's holding it up? And as we're walking along, literally, I says, well, you know, it's a tough situation because there's a lot of scientific problems. It isn't a logistic problem. It's a scientific problem. But all of our scientists are siloed. We got basic researchers, vaccinologists, immunologists. It would be really nice if we could put them in one place, like in a vaccine research center. And as we got close to the door, he turned to his chief of staff, and he said, can we do that? And he said, of course we can do that. You're the President of the United States. You can do whatever you want to do. And I thought he was kidding around. I thought he was being maybe just trying to be nice to me about that we can actually do that. But he surprised us, because 5 months later, when he gave a commencement address at Morgan State University, he announced, I'm pleased to announce that the NIH will establish a new HIV vaccine center dedicated to this crusade. And that's what we have, which is the VRC, which many of you know, which turned out to be an amazing investment in research. The chief of staff at the time, I forgot his name, was Leon Panetta, who was chief of staff before he became the Secretary of Defense. Not only we're doing HIV, but a number of the emerging diseases that we're talking about right now are being developed in the Vaccine Research Center. Lesson, you get leaders involved, they can do very, very important things with the snap of a finger. So I was trying to give a little hint to these people as I was doing that. But the other thing that we had during the Clinton administration was a new phenomenon, and that is a re-emerging infection, namely infection that's been around literally forever. West Nile virus has been with us for as long as time, and it was in Africa and in the Middle East. But what happened? Because of travel in 1999, either a mosquito, a bird, and or a person got on a plane in Tel Aviv and landed at Kennedy Airport on Long Island, and then all of a sudden, what did we have? For the first time ever, we had West Nile in the United States with a few cases early on, and then all of a sudden it exploded, so that right now, West Nile, which is transmitted by a mosquito, a vector-borne viral infection, is endemic in the United States, and it will always be endemic in the United States. And the reason I say that is that we don't have a vaccine, and we tried to develop a vaccine. We had a good candidate. Another lesson to be learned, you have to get industry involved. We did a phase 1 study, showed it was definitely safe and definitely good immunogenicity, but we couldn't get a pharmaceutical company to partner with us because no one felt you can broadly vaccinate people for West Nile, which is really an interesting concept, which is why we get much more involved in doing a lot of the work to get companies involved. Let's move on to George W. Bush. Again, it continues to translate into HIV, but other things happen. Remember, just to remind you, my theme to them is bad things happen in the first or second year of your presidency. So George Bush was inaugurated in 2001. What really bad thing happened in 2001? 9/11. But juxtaposed to 9/11 was something that involved us in the biomedical research community, and that was the anthrax letters that were sent to Senator Leahy, to Senator Daschle, and to certain media personalities like Tom Brokaw and the editor of the Post. All of a sudden, bioterrorism became a very important issue for us. We did not know at the time that the anthrax attacks was not Al-Qaeda, but for those of you who were around who lived through that, everyone thought that it was and that we were going to have an attack soon thereafter. So what we did is that we put together a strategic plan for biodefense research as well as a research agenda. One of the best things that I think that I did, and I will get into it in a second, is that when we assumed the responsibility of the extra money they gave us for that, I first discussed this with who wasn't Secretary of Homeland Security, because it was only the Office of Homeland Security, Tom Ridge, that I would accept the responsibility to get the NIH to get involved, but we had to use some of the money for things that were not just bioterror agents, but there were agents that were actually naturally occurring. So we did what we were supposed to do. We developed countermeasures against the 5 biggies: smallpox, anthrax, botulism. We developed antitoxins, better vaccines for smallpox, antibiotics for plague, vaccine trials for Ebola. Note, we were doing Ebola vaccine well before we knew Ebola was going to be an actually naturally occurring problem. But something happened that really turned it around, and that was in February 2002. The president was going up to the University of Pittsburgh to give a speech related to a really neat thing that they were doing at Pittsburgh. They developed an electronic system that could monitor all of the emergency rooms throughout the country and be able to tell if there's blips of unexpected diseases that might indicate a subtle, undetected terror attack that we didn't even know of. So the president went up there. I didn't get a chance to talk to him. I flew up with him on Air Force One. On the way back, he got very talkative. He asked me to come into his stateroom, and he asked me this question. He says, "Tony, what scares you the most about microbial threats that a terrorist might use?" And I figured, hey, as long as I have his attention, I said, "Mr. President, I worry actually more about the natural occurrence of an influenza pandemic or some sort of a plague that resembles HIV." And it was that allowed us to then truly move money to be looking at naturally occurring infection. And that's when we were talking about that the worst bioterrorists may actually be nature itself. And sure enough, in 2005, we had the H5N1 bird flu that scared the heck out of us. You remember, we spent a lot of money to make vaccine because it was a bird flu that jumped from chicken to human, was highly lethal, 30% in humans, but did not spread efficiently from human to human. Nonetheless, we still spent a lot of money trying to make a vaccine, which we did, to stockpile, which we never used. And I'm going to get back to that in a second. That's going to be the biggest argument in the world for a universal flu vaccine. But we did it. We developed a pandemic preparedness plan, and that's exactly what we did. We started with the CDC and the FDA to have a consortium of effort to develop pandemic preparedness. But also, during George Bush, was another interesting thing. SARS. Now, SARS was and is a brand new infection. It's a coronavirus, which is a class of virus we know a lot about, but SARS was new. And SARS was really very interesting. It captured the attention of the entire world, was an economic disaster for certain countries for a while, including parts of Canada. How did it happen? I refer to this really as a prototypic example of a classic epidemiological happening. So if anybody is an epidemiologist here, you should really get very excited about SARS. I do. It started off in Guangdong province in China. The Chinese were not particularly transparent about what was going on. We knew that there was an atypical type of pneumonia there. They said it might be flu. Well, we weren't quite sure until someone left Guangdong and went to Hong Kong and stayed at the Metropole Hotel in Hong Kong. And what happened at that hotel is that 19 people were infected by this respiratory-borne virus. And what do people do when they go to Hong Kong? They generally don't stay in Hong Kong. They get in a plane, they go someplace else. They did. They went all over. And what did we have? A classic example of how the travel situation leads to outbreaks. The bad news is that we had an 8,000-person outbreak with almost a 10% mortality. We rushed to make a vaccine against it, and we did. We actually started off and we did a vaccine that was a DNA vaccine that was the fastest from the time of sequence to the time of phase 1 trial, but we got better and better over the years. Fortunately for us, good public health measures literally got rid of SARS by itself. In fact, they declared victory, and that was without a vaccine and without a drug. I want to spend a minute with Bush because you can't leave George W. Bush without mentioning PEPFAR, and which is the reason why whatever issue you have with President George W. Bush, he did something that no one else did, was to literally save millions and millions of lives by the PEPFAR program. In 2002, he sent Tommy Thompson, who was the secretary of HHS, and I to Africa and asked me one question and one mandate. Go to Africa and find out if we could actually transform this disease in this region of the world, because he said, his exact words, we have a moral responsibility if we have drugs that we know are now essentially getting people to live normal lives in the United States and the developed world. We have a moral responsibility as a rich nation to make that happen in a place like Africa and other developing countries. But he didn't know if you could actually do it. So my job was to see if that was feasible. So he sent me there. We visited these countries, and we went into the bush. And this is an 18-year-old woman, part of an organization called the AIDS Service Organization, who actually was in Uganda and proved to me she got money from a philanthropic organization, not a lot, but she was able to take drugs here on her motorcycle, and that's me following her in a Land Rover. No way I was going to ride in a motorcycle in Africa. Taking this picture of her, we got to a village and we started distributing drugs, and it turned out everybody knew what they had. They took the drugs and they were doing well. So over the next 8 months, we put together a program with the help of some very, very helpful White House staff. I presented it to the president, and after much discussion, OMB was totally against this. They thought it was too much money. So even back then, they were very, very conservative about spending a lot of money. But the president wanted it, and the presentation that was that it would be a $15 billion program over 5 years to prevent 7 million infections, treat 2 million people, and care for 10 million people. As it turned out, he accepted it. He announced it at a State of the Union address. We named it the President's Emergency Plan for AIDS Relief. And over the years now, it has done spectacular things. It's been responsible for saving at least 3 million lives and preventing infection in over 2 million babies. So this is unquestionably the most important public health endeavor ever embarked upon by the United States, because a president of the United States decided that he wanted to do something. And I mean, we were his instrument, but it was he who did it. Okay, now Obama had a real difficulty, not difficult, he was terrific, Obama, but he had a problem because he had a lot of emerging infections. So, getting back to now the theme, first year is bad. Okay, so he was inaugurated in January of 2009. So what happened in 2009, the first pandemic of the 21st century, H1N1? So at the end of the 2008-2009 season, we were going through a regular season. Everything is supposed to disappear around March. You know, you peak up, it goes down around March. But we started noticing that there was some interesting infections on the West Coast that didn't appear to be the standard H3N2 that we were seeing. So everybody was looking at China and saying the next pandemic is going to come from China. But it didn't come from China. The next pandemic was the swine flu, which happened to emerge in California and in Mexico. So this is the map in March 2009. In April, it became clear that this wasn't going to be staying confined. So here's an interesting thing that we should realize about when you hear me rail, sometimes crazily, about why we need a universal flu vaccine, is that we know it takes about 6 or 7 months to grow virus in eggs and in cells to make it for a vaccine. So we said, hey, it's April. We got 6 months. The flu season usually starts really peaking in November and December and January. So it's April, May, June, July, August, September. We're good to go. We can get a vaccine. And that's what Ann Schuchat and I told the Senate Appropriations Committee in April, that we're going to do our best to get a vaccine ready to go. Then what happened? The children went back to school in September. And instead of it peaking in January and February, this is a telling slide. What's wrong with that slide? The blue line is where the red line should be, and the red line is where the blue line should be. So the blue line is the infections, and the red line is the availability of vaccine doses. And as you can see, it had already peaked at the time that vaccine doses were fully available, which tells us we really have a problem with having to grow the virus to make a vaccine. So all of a sudden I had to testify before a congressional committee about, what happened with the vaccine? And it was at that point that we started to talking about the need of really needing a universal influenza vaccine. So let's quickly go through Ebola. Again, this was something that is so many lessons from Ebola. Ebola was a disease that was first recognized in 1976. There were 24 outbreaks, usually anywhere from a few cases to 100 cases, usually through Central and Southern Africa, until the perfect storm came in 2014-16. 3 countries, porous borders, naive to Ebola, had never seen Ebola before, but importantly, they had no healthcare infrastructure, and they had just gotten over some terrible civil wars, and they were very mistrusting of authority. We did something. It was, a terrible disease. It had anywhere from a 40 to a 90% mortality. What we did at NIH, mostly with Cliff Lane, who gets all the credit in the world for this, established a research program, started testing vaccines, one of which now works, started testing drugs, one of which has some pretty good results to this. But the issue that actually really got the country in what I would consider an understandable but unnecessary panic, because people were dying like anything in Africa, and we knew sooner or later a case was going to come to the United States, and that's exactly what happened. On September the 9th of 2000, it was 2015, on September the 9th, for 2014 actually, sorry, a man named Thomas Duncan left Monrovia, had been exposed to an infected person, got infected. He was trying to help. He was bringing a person in a cab to go to a hospital who was infected. The only thing is that when he got to the airport and asked, did you have any exposure to someone with Ebola, he wanted to go to Texas to see his girlfriend and her children, so he said, no, I had no exposure. He had no fever, so he got on the plane. He landed in Dallas. He still had no fever. Then he he woke up one morning and developed some symptoms and a low-grade fever. Went to the emergency room, and one of the things you learn in medical school is when people come in with sort of unusual things, you always ask them, do you have a travel history? And they didn't, so they didn't know that he had just come from Liberia. So they sent him home with a Z-Pack and acetaminophen, and then he really got sick. And he went back to the emergency room in dire straits, immediately got admitted to the emergency room, and unfortunately, he infected 2 brave nurses, Nina Pham and Amber Vinson. And this was now, everybody was worried about Ebola in the United States. And here it was, but the public tend to think there was going to be an outbreak. And we were saying there couldn't possibly be an outbreak because you only get Ebola when you come into very intimate contact with the bodily fluids of someone who's acutely ill. Yet there was an interpretation that since the nurses got infected, anybody could get infected. And that was really a very, very tough time. In fact, USA Today said it in an editorial, fear spreads faster than Ebola, our view. We at NIH were one of 3 designated centers that were trained to take care of Ebola patients. Now that means you got to learn how to take care of a patient who's highly infective with a disease that can be up to 80 or more % fatal when you get infected. We turned out that it isn't, and I'll show you that that's an important lesson. But you had to learn how to take care of patients with a spacesuit on, which isn't particularly easy to do. They immediately transferred Nina Pham to us because they felt in Texas that there was just a disaster in Texas. It was, I think, a little bit unfair to the people in Texas, but they did it anyway. So we started taking care of Nina Pham. She came quite sick, but not really in dire straits. So she was with us for a couple of weeks. And I decided at this point that when we discharged her, to discharge her publicly. Some of you may have been around when we did that. and I specifically put my arm around her and hugged her in front of the 12 TV cameras that were there and all the newspapers, for the simple reason that there was a terrible stigma against people who had Ebola, that even when you recovered from Ebola, it was like you never ever could enter society again because you were a threat. So that's the reason why this made the front page of the Washington Post. And immediately after that, we took it down to the White House, and President Obama did the same thing in front of a lot of photographers. He hugged her. Note, he hugged her after I hugged her, but that's okay. But then something happened that turned around the entire issue of something that was felt to be 90% fatal, because it wasn't, because we had a patient who, I can't give you his name because he still wants to be anonymous. He was a patient of Paul Farmer's. Paul had a unit in Liberia and Sierra Leone, and one of his physician assistants got infected. And we decided we were going to, as one of the three groups, we decided we would admit him to our, and this is our staff in the back entrance of the clinical center. Here we are. Here, I decided that since I had to ask my own staff to take the risk, that I would do it myself too. So I decided I would join them. It was actually really quite telling to take about 2 weeks off and just go and rotate through an intensive care unit. And here I am with one of our, the rules were you have one infectious disease person and one intensive carist. And this is Dan Chertow, who's on the staff of the intensive care unit at the clinical center. And this was 2:45 in the morning, getting ready to go in to our shift. And when I say shift, you're only allowed to be in the room for 2 hours. You have to come out because you get tired. When you get tired, you make mistakes. When you make mistakes, you get infected. So we followed the rules, and I just rotated through. And here we are putting on our stuff, and here's Dan and I taking care of this patient. This was the sickest patient that I had ever taken care of, and I've taken care of a lot of sick patients. But the interesting thing is that under exquisite intensive care with no drugs and no intervention except supportive care, he walked out of the hospital, and we've been following him in clinic now, and he's perfectly well. So we turned around the paradigm that when you get really sick with Ebola, you're a lost cause. You're not if you have the ability of intensive care. So finally, Zika. Zika is another interesting saga. Like I said, President Obama had a lot of issues when it came to having to deal with these. So Zika is an interesting infection. It was a brand new infection, first discovered in 1947, first infections in 52, went under the radar screen for a couple of decades, and then there were two outbreaks, one in Micronesia in 2007, one in French Polynesia in 2013. And nobody ever actually thought much about it until it got to Brazil. And Brazil was the perfect storm. Big country, a lot of mosquitoes, immunologically naive. Why did we think it was inconsequential? We thought it was inconsequential because 80% of the people who got infected had no symptoms. The 20% who got infected, they had minor symptoms. Headache, malaise, arthralgias, myalgias, conjunctivitis, and fever usually last a week and then went away. It was only when a lot of cases accumulated did we find out that there was a devastating effect of Zika, and that was the microcephaly, which actually, as you all know from the amazing publicity that it got, was a major issue, particularly in the northeastern sections of Brazil. Not only microcephaly, but other issues like mental retardation, blindness, hearing abnormalities, and a variety of other difficult problems. And again, the NIH jumped on this, and the big issue that we did was to develop a vaccine, particularly a DNA vaccine, which was, again, developed by the Vaccine Research Center. I show you this slide because it's a really interesting slide of how when you perfect a vaccine platform, DNA happens to be just an example. There are multiple other platforms that I remember when I showed you SARS. That was the quickest we ever went from sequence to phase 1 trial. That was 20 months. We did it with 2005 H5N1, 2009 H1N1. With Zika, it was stunning what the Vaccine Research Center did under the leadership of John Mascola and Bonnie Graham and others, is that they went from the time that we sequenced it to the time it went into phase 1 trial in less than 4 months. Unquestionably, the world indoor record for that. It is now in phase 2 trial in South America. So I said, these are the 5 we knew. What's going to happen with the next administration? And the answer is, if you say what's next, we really don't know. And that's really the lesson. But there are certain things that we do need to pay attention to. Zika is not of any consequence now. There are very few infections in South America. There are one or two that we've seen in Texas, but it's not going to go away. Chikungunya came and didn't go away. Dengue came and didn't go away. We're going to see Zika, which is the reason why we're doing a vaccine trial. So if 4 years ago on rounds I had asked our fellows, who knows something about Zika? They'd look at me like I was crazy. Zika, what? What are you talking about? Nobody ever heard of Zika. Right now, there are diseases out there that are vector-borne like Myaro and Oropouche. So I said on rounds the other day to our fellows, what do you know about Oropouche virus? And they looked at me like somehow I was smoking something. But the fact is that these are the kind of things we need to keep an eye on. We already know we're dealing with H7N9 influenza. An interesting thing, H9 is a chicken flu. In 2013, we had the same thing as H5N1. Humans get infected, 30% mortality, doesn't go easily from chicken to human. I mean, from human to human. So it's a dead end when it gets to human. But you were afraid it was going to mutate. So we developed a vaccine for a couple of $100 million in 2013. They had another little mini outbreak in China in 14, 15, 16. Then what happened in 17? We had the same thing. It mutated, but now the antibodies that was able to neutralize the 2013 vaccine doesn't neutralize the 2017 vaccine. So we have to start all over again and make another vaccine for a couple of $100 million, which, unless you're asleep, should actually prompt you to say what we really need is a universal influenza vaccine. It was for that reason that we held a workshop here in June of 2017 to develop a strategic plan looking at the conserved components of the influenza, particularly the stem region of the hemagglutinin molecule. And that's what really everyone's working on, because you know that the antibodies against the head are protective. The trouble is all those red circles on that, those are all mutations. Where if you look at the few mutations you see in the stem. So if we could figure out a way, and it's not going to be an easy scientific issue, to make antibodies particularly against the stem and not the immunodominant head, we could get close to developing a universal flu vaccine and get rid of growing it in eggs or growing it in cells, doing recombinant DNA technology like shown on this particular slide. And hopefully in the next several years, we'll at least get close to getting a universal flu vaccine. And these are some of the selective approaches. So in summary, and this was after the meeting, Health Affairs blog wrote up, said, and it was a quote from me, if history has taught us anything, it's that the new administration is likely to experience at least one infectious disease crisis of significance. And the lessons we learned are on this slide. I don't need to go over all of them because I've been talking about them for the last 45 minutes. And that is, we need surveillance, transparency, coordination, et cetera, et cetera. So at the end of the day, the lesson that I left with them is that infectious diseases that emerge are truly a perpetual challenge. They've always been with us. Even before we knew the germ theory, they were with us. They're with us now. I've just given you a talk on it, and they're going to continue to be with us forever. So for that reason, we need to be essentially perpetually prepared for what is something that's going to be perpetually with us. So I'll stop there. Thank you.
We have time for just one or two questions, and please use the microphone. Question from someone? Then we'll ask you to perhaps say, what do you think will be the next challenge with the government and how they will respond? What is your prediction?
Well, I mean, my concern has always been the issue of a respiratory infection that is going to be a very, very bad influenza bordering on a pandemic. We're having a very bad flu year right now. It's not pandemic. It's a virus that's been around for a while, but it's an H3N2, and it's a real problem. I can't predict. I mean, you're asking me a question that was the bottom line of what I said. You can't predict, and that's the reason why you've really got to be ready for everything. But the one thing that I worry most about is a respiratory disease to which we have no underlying immunity and we have no countermeasure, and we just have to be ready for that. And I don't think you're ready for that by picking out and guessing. You've got to develop platform technologies for both vaccines as well as drugs, multiplex type of diagnostics and multiplex drugs of a broad spectrum nature.
Yes.
There's been a talk about antibodies to certain viruses. For example, dengue gives this worse disease if another strain is also true to Zika. Can you elaborate on that?
Yeah, the issue with Zika is not an issue. The issue with dengue is an issue. And what the point that was being made is that dengue is unusual because there are 4 serotypes of dengue, 1 to 4. Now, the problem is that in a very small percentage of cases, well, first of all, forgetting vaccines, we know that in some individuals who get infected with one strain of Zika, with dengue, and then get infected later on, they get an enhanced response and can get one of the more serious manifestations of dengue that could lead to hospitalization and death. It's very rare, but it happens. It truly is antibody enhancement. The problem that you're reading about in the newspapers now is that there was a vaccine made by Sanofi that actually has a pretty good antibody response against 1 and 4, but a very weak response against serotype 2. So there was the concern, and now the reality, that a very small percentage of people who got vaccinated, particularly children who had a suboptimal response to 2, who then got infected and had enhancement of whatever subtype they got infected at. And there's a big, big problem politically and socially or what have you about that. So what we need, the answer, is a dengue vaccine that can give uniform good response against all 4, because dengue vaccine is spectacular if you have it against all 4. If you get against one but not the other, you have the danger of enhancement.
Is the mechanism of this effect known?
People say they do, but it isn't. What it is probably it allows the virus to be bound by the antibody but not neutralized, and yet taken up by a cell more efficiently, which then allows it to replicate in whatever cell it replicates in.
It's a great talk, Dr. Fauci. I was just wondering if you had a preferred strategy for a universal flu vaccine, maybe taking off the globular head, going for a more conserved region on the surface glycoproteins, or I was just curious about your opinion on that.
Well, my opinion is that each of those things that you mentioned are certainly worth trying. The head is immunodominant. Peter Palasi is working on a chimera, putting a different head on a stem and not distracting the immune system. Barney Graham is working on a nanoparticle approach where he first started with taking the entire hemagglutinin and putting it in a nanoparticle, which is multiple expression that looks like a little virion. It's almost like a viral-like particle. And he did it with the whole hemagglutinin, started a phase 1 about 3 weeks ago, and he's now going to move on to a phase 1 of just the stem alone. So if you would ask me to throw my quarter and bet what I think would be the best one, I would think that a stem alone, either as a nanoparticle or as a viral-like particle, is the way to go.
Thank you.
Thank you, Dr. Fauci. Maybe at the end we will have some more questions.
I have to run, unfortunately.
You have to run?
Well, maybe one more.
Question?
So the problem today are also emerging zoonotic diseases. In your opinion, what has to be optimized, or maybe additionally, or which approach is additionally necessary to get a better surveillance on the emerging of zoonotic diseases from animals and maybe also foodborne diseases?
Well, you make a very good point. Over 70% of new emerging infections are zoonotic, that they come from animals. And many of the ones I've spoken about do. And there is a movement called One Health that you might be familiar with, probably otherwise you wouldn't have asked that question, is to essentially get people who are concerned about animal diseases working more closely, both in understanding pathogenesis, but also in surveillance, so that you could determine things that are happening in the animal world that are a hint that they may jump to the human. In fact, if we had had good pig surveillance back in 2009, we likely would have realized that there was a virus circulating in pigs that was developing receptors that were easily adaptable to humans. But we didn't. We didn't know it until the people got sick. So that's what we really need, is more emphasis on the interface between animals and humans.
So the WHO and the FAO have to work more closely together?
Yeah, I guess
that?
so. Yeah.
Okay, thank you.
Good. I'm really sorry I have to leave, but I have another meeting. I'm sorry that I have to go. All right.
Thank you very much. So Dr. With Allison, please. I think you have your presentation here. Just give a second. He's going to turn it on.
I'd like to first add to one of Dr. Fauci's lessons learned. Don't follow Dr. Fauci in a talk.
Perhaps you have a more difficult challenge.
So perhaps you think, since we're talking about the blood supply and infectious diseases that impact the safety of the blood supply, that we're going to get more narrowly focused. But actually, that's not going to be the case. Quite the opposite. I thank you very much for braving the black ice coming in here, and for the millions at home who are watching from their desks or who will be watching on YouTube. Thank you very much. It's great to be here with you. So I do have a few disclosures. The NIH site PI of this Zika virus IND test, nucleic acid test by Hologic, and also the Department of Transfusion Medicine blood bank utilizes the Cirrus Intercept system. It's the only FDA licensed test for pathogen reduction of our platelets, and I have no financial interest in any of that. And the opinions expressed are, of course, my own and don't necessarily reflect the position of the U.S. federal government. So just a few learning objectives. I'm just going to give a brief background on the U.S. Blood supply indications, indications for transfusion impact, just so you get to know the population, kind of the epi of it, if you will. I'll talk about strategies that we currently use to protect the blood supply from current and emerging infections, and future strategies for protecting from emerging infections. I'll define those infectious agents known and potentially emerging, and then we'll go over the advantages, limitations, and impact of these strategies. And most importantly, I'm going to cover it all in 30 minutes. So just as a background, we collect, the U.S. blood supply, we collect over 13 million red cell whole blood units. Of those, we transfuse over 6 million. We collect over 2 million platelets, over 4 million plasma components, and over 1 million cryoprecipitate. There are other components, specialized components as well, like granulocytes, which we provide to the NIH, to investigators doing research in the NIH Clinical Center. Most of these, almost all of these, these components are collected by major blood centers. Now there are only a few of them. Major blood organizations like the American Red Cross, Blood Centers of America. In our blood bank at the NIH Clinical Center, we collect about 10,000 donations per year. So just a little bit of a background. I also wanted to give a background. What are the most common indications for transfusion? What does the population look like? So this comes from, this is actually a stat brief from the Agency for Healthcare Quality and Research just a few years ago. And this is the number of hospital stays that require red cell transfusion. So specific to red blood cell transfusion. Those are the majority of our transfusions in the United States. You can see sepsis, GI bleed, not surprising, acquired or hereditary anemias. So that also includes bone marrow failure, hip fractures, and so on. So what's the positive impact of blood transfusion in the U.S.? So about 10% of Americans who are admitted to the hospital require blood. You can imagine that. A large proportion is used for surgeries. Another large proportion is allocated for patients with cancer. And it's been projected that over 4 million Americans would die each year without having blood transfusion. So a significant public health impact. So what's the impact, flip to the other side, what's the impact of transfusion-transmitted infections? Well, the worst, of course, would be death. This is pretty rare, luckily. These data are spread across, come from several different surveillance systems in the US and France and the UK from 96 to 2007, but even when death from a transfusion-transmitted agent is significant and likely preventable, death from transfusion-transmitted infections comprises 14% of all transfusion-related deaths. A lot of these come from transfusion-associated sepsis, many from babesiosis. One was from variant CJD, which is a prion, Creutzfeldt-Jakob disease. One was from malaria. And each of these study investigators also note that these surveillance systems aren't all-encompassing, and this is the numbers are likely much greater than this, but still relatively low. But there are others, besides death, there are other significant complications like severe illness, prolonged hospitalization. There may be impacts to the success of bone marrow transplantation, engraftment potentially, and we just talked a little bit about Zika, potentially birth defects related to Zika-infected blood transfused to pregnant women. So what are the strategies used to protect the blood supply from transfusion-transmitted infections? Well, I pulled this slide from Harvey Alter, who's, I think he ran out, but no, he's sitting over here. I really like this. I don't know if he made this up or if this comes from somewhere. He didn't charge me for it, so that was good. But this is the protective triad. So what do we do? We use donor selection. We use blood screening techniques. And more recently, we're using pathogen inactivation. So let's start with donor selection. The blood supply in the U.S. now is 100% non-paid, 100% volunteer donor system. Prior to 1970, actually many of the blood donors were paid for their donations. And in many countries, actually I was just doing work in Mongolia just a few years ago. In Mongolia, they switched to an all-volunteer system. Many countries, many non-Western countries or developing countries are still utilizing paid donors, although it's quickly switching to volunteer-only donors. But what's the significance? This is a high-risk group. These are data from Dr. Alter's heart study, the NIH heart study, which is a prospective, retrospective study of post-transfusion hepatitis. So blood transfusion recipients who developed hepatitis. And what they found was that, as you can see, 51% who developed post-transfusion hepatitis received their blood from paid donors versus only 7% from volunteer donors. So this quickly was translated into U.S. health policy, and this exclusion of paid donors contributed to probably the most significant reduction in transmitted hepatitis. Most of those, retrospectively, we determined to be viral hepatitis. So another method that we use, low-tech method. How many people in here are blood donors or have been blood donors in the past? So every single person raised their hand in here. That's great. So we thank you for your donations and your service to patients. So every one of you who have gone through the process and know these questions really well, because you're asked these questions every single time you donate, I'm just going to go through a few, and mostly the ones that are related to preventing risky transfusions, transmission of infections. So very simply, we ask, are you feeling well? Are you sick? So we exclude everyone who appears to be symptomatic or who on this survey says that they're symptomatic, they're sick, they're taking antibiotics. And this should eliminate actually a significant proportion of infectious agents. I give an example here. For instance, Zika virus is, maybe it's not the best example because Zika virus is only symptomatic in 20% of cases, but still with this question, hypothetically, you should be eliminating 20% of potentially Zika virus transmitted infections. A better example may have been either dengue or chikungunya, which have a much higher rate of being symptomatic, maybe 50% or higher. So hypothetically, you should be eliminating half of that risk just with these questions. There's some questions about sexual contact and exposure. I put this on here because I want to mention it on the bottom. One question is, have you had if you're a male, have you had sexual contact with another male? Interestingly, this, and based on newer data and risk studies, previously, if you were a gay male, you were excluded indefinitely from blood donation, but just recently, this policy has changed. And so everything here that I'm showing on this list requires a 12-month deferral period. This is a very interesting one. How many people in here have been in prison for 72 hours or more? There's just a few people raise their hands. This is very interesting because if you've been in, this is meant to reduce the risk of hepatitis C, HIV, but in this situation, this guy will not be able to donate blood for 12 months from when he's released from prison. Of course, he's also too young to be a donor. It's a double exclusion. There's some travel-related questions as well. One is, have you been outside the U.S. or Canada? And then our screeners will go into more detail about which particular countries is this meant to screen out for the risk of malaria. And then there's a deferral period associated with that. There are other questions based on geography, based on travel, and time spent in areas, for instance, in the UK or Europe or France, that are meant to help remove the risk for variant CJD, a prion, which there is no test for. So as I said, the donor health questions is a questionnaire. It doesn't seem like sexy science, but I wanted to present it. I'm a public health guy. A lot of public health interventions that work really well aren't sexy science, but are really effective. And I want to show you in the next slide why it's an example, a case and study of why this is so effective. So this is a slide from the Sacramento Blood Center. And it shows that the rate of transfusion-transmitted HIV. And you can see the first AIDS cases. Okay, you're not here. Even with my booming voice. So on the recording, it'll just be my mouth moving. So this represents transfusion-transmitted HIV. The first transfusion transmitted AIDS case was reported here in the early 80s, and the community conducted outreach to the gay community, particularly gay men. Gay men were identified at the time as being high risk for HIV. Were then excluded from blood donation. And what's incredible about this is even before HIV was discovered, even before we identified the agent, and even before we developed a screening test, because of a donor selection method based on risk stratification, the risk of transfusion-transmitted HIV was decreased really precipitously, significantly. So to the second one, blood screening. This is a timeline of donor screening in the U.S. So starting way back in the 50s when we started screening syphilis. Each of these, it's kind of like a law. When you add one, you keep it forever, and it almost never goes away. There's only one exemption or exclusion up here. We added hepatitis B surface antigen. The first tests for HIV were antibody tests for hepatitis B core, HTLV, antibodies against hepatitis C, then added HIV-2, covering both HIV-1 and 2. The first nucleic acid tests for HIV and hep C RNA were added during this period, followed by West Nile, Trypanosoma cruzi, which is the agent that causes Chagas disease. Hepatitis B DNA was actually added later after the antibody and antigen testing. We've more recently have added selective Babesia testing, Babesia macroti, which has a higher risk of transfusion transmission in the northeast of the U.S. and in several states. So this is actually currently under an IND, an investigational new drug application. And as you know of the Zika virus outbreak in blood. We just had news of recently of having a licensed, we've had Zika virus testing, RNA testing under IND for the past year and a half. And just in the end of 2017, we now have an FDA licensed Zika virus test. So just to summarize this, we're now routinely screening blood donors for about 7 agents, and then there are 3 that are really our special cases. CMV I didn't have up here, but that's testing for immunosuppressed patients. Trypanosoma cruzi that causes Chagas is tested just in first-time blood donors. So what are the limitations of blood donor screening? Well, one problem is a strategy is typically reactive rather than preventive. So I want to go over, this is another slide that I adapted from Harvey Alter that I really like, because I think it rings very true, having worked in public health many, many years. How does the blood community approach infectious threats to the blood supply? Well, first, we learn from surveillance systems, if they exist, if they're in place, if they're sensitive, from CDC, WHO, maybe the local newspaper or other sources of new cases of agents that could be transfusion transmitted. We then look for evidence and try to prove that it is indeed a new transfusion transmitted agent. Sometimes we do nothing until the magnitude of the problem increases, and as Dr. Fauci said, that was the criticism for Zika virus. That was a criticism also not in blood, but in general in public health in the response to Ebola. If you do nothing and the magnitude increases, this can be very costly, both in money, but more importantly in lives. Another strategy that I went over that I showed was very effective with HIV, and we can do pretty quickly, is deferring donors based on risk or geography. It's relatively inexpensive. You can do it pretty quickly. Logistically, it's difficult, but you can do it pretty quickly. But it still has the limitations of recall bias or people not remembering or not considering the questions to be maybe pertaining to them or be significant. I feel fine. This can't be me. So the third is we, as I showed in the prior slide, we add another antibody test, or we add another nucleic acid test once it's been developed and licensed. And as you might imagine, it's very expensive, and it takes quite a bit of time. We're getting better at it, but we're still looking at 6 months to a year for an IND, longer for licensure. So what's the cost of screening? I wanted to give the case of Zika virus. Ellingson in Transfusion 2017 did a projection of the cost of doing individual nucleic acid testing for Zika virus in all blood donations versus mini-pool testing. Mini-pool testing is, instead of doing individual testing, you pool several together. You lose some sensitivity, hopefully not too much, and you lower costs by screening in combination. And they projected the cost to be about $137 million per year. Mini-pool testing was a little bit less. But let's do the math of this. What does this come out to? I'm basing these calculations on data from ARBONET, which is the CDC surveillance system for Zika virus, and the American Association for Blood Banks has another surveillance system. And in the first 9 months of 2017, they found only between 9 and 14 Zika virus positive donors. So relatively low, much lower than the prior year. And I'm not going to go through the math, but that comes out to the total costs of between about $7 and $11 million per Zika virus positive donor. So cost is a limitation here. As I mentioned, these are the agents that we're currently screening for routinely, and these are the special cases. But there are many, many, many other agents that are potentially transfusion transmitted. What I'm presenting here is a coding scheme from the American Association of Blood Banks, showing all the potential emerging agents where they ranked based on evidence using an expert committee of highest risk being red. So these are, and risk decreases this way. Highest risk, red, is agents that are likely to cause death or severe disability, or much more likely to be transfusion transmitted. So if you look at these numbers, and there are many more than these as well. These are just the ones that this group ranked a few years ago. We're fully screening just 24%, and over 2/3 are not being screened. So our blood supply is at risk for any number of these agents. However, despite that we're only screening routinely for 7 agents, I wanted to give you a case in point of the significance or the impact of screening, using screening tests for blood donation. So this is a slide. This is coming from the NIH heart study, a study of post-transfusion hepatitis. So blood recipients who developed post-transfusion hepatitis from their blood transfusion. So you can see back here in the late 60s to 1970, the baseline rate before screening of transfusion-transmitted hepatitis was about 30%. When we added in 1970 this first-generation hepatitis B surface antigen test, as well as what I said before, excluding men who have sex with men, we saw the single greatest decrease in risk for post-transfusion hepatitis, about 20%. Additionally, when the agent that caused hepatitis C, the hepatitis C virus, was identified and a test became available, we We saw further reductions. And now today, due to screening as well as some donor mechanisms of donor selection, risk stratification, we're now, or as of 1997, we're at a near zero. I say near zero, but there are a lot of zeros after that decimal point. We're at essentially a zero risk of transfusion-transmitted hepatitis in the United States and in all Western countries now. So what are future strategies for screening of the blood supply? I showed that long list of emerging potentially transfusion transmissible agents. Well, one potential strategy is multiplex testing. So what's multiplex testing? This is screening, taking a single sample from a patient and testing for the DNA or RNA. So it's a nucleic acid test, the DNA or RNA from all infectious agents that you know about. So let's say from that list up to 30 different infectious agents that can be transfusion transmitted and testing them all at the same time. It still has to be highly sensitive despite testing all these agents at the same time with the same sample. It will require fast turnaround time. It has to be inexpensive and high throughput, those match together. And I think also critically is the list, as Dr. Fauci showed, the list is just going to keep expanding and we can't predict what's going to be next. So it will require us to add new agents rapidly to respond to public health emergencies. If there's anybody from FDA in here or listening, please perk up a little bit for this last point. There's currently no regulatory pathway for this. This would have to be a new paradigm of adding new agents to a platform, to a multiplex platform quickly. So for instance, with a platform that we're developing in our laboratory that would detect up to 30 different transfusion-transmitted agents, we could have added, in fact, we did add Zika virus, probes to detect Zika virus, validated those, printed those on a chip, and had those available within a month. And so that could be done even more quickly in these types, in a public health emergency setting. And if we knew up front what would be required for the IND, what would be required for the validation. So I think this is doable, but it will require considerable paradigm change in this area. There are currently multiplex assays. There are 4, 2 of these are in use from Roche and GenProbe. One's PCR-based and the other transcription-mediated, amplification-based. But these are licensed to these current assays. Although they're multiplex, they only currently detect for the big 3, for hepatitis B, hepatitis C, and HIV. And they are nucleic acid tests. But as I mentioned, here are the 3 from the current multiplex tests, the triplex. But again, to hammer it home, that's just not sufficient. So there are multiple technologies, multiple platforms that are being developed for multiplex detection of infectious agents, although few, if any of these, are actually being used or developed to detect transfusion, specifically transfusion-transmitted agents, and in the context of a blood transfusion. So the Department of Transfusion Medicine approach, the infectious diseases section, and my lab is developing a microarray approach for specific detection of transfusion-transmitted agents. And this is a cartoon, a simplification, but I think explains part of the process. So with our process, of course, there's a clinical blood sample, there's nucleic acid extraction, We use random PCR amplification and coupling to fluorescent dyes, and this is actually the technology. This is where, I guess the rubber meets the road. This chip includes 15,000 60-mer oligonucleotides that are probes for about 30 different agents, and it's set up now in an 8-array format. So one patient, you could test one patient with each of these for about for about 30 different transfusion transmitted agents. And this goes through a whole process of validation, printing, and then revalidation. We then move to clinical signal detection analysis, and our output looks like a heat map. These are actually 3 outputs from dengue virus 1 through 4, hepatitis C, multiple genotypes, and HIV 1 and 2. So just some preliminary data from our probes. This is not multiplex. These are actually the individual agents. But for the first generation of our chip, which is an RNA-based chip, all the significant RNA-based viruses can be detected individually at about a log 3 to mostly log 3 to log 4 limit of detection. And we've developed currently our multiplex, if you will, is currently a triplex combining chikungunya virus, dengue virus, and Zika virus. And we're, in addition to detecting these individual agents, we're also detecting these 3 agents combined with a limit of detection of 3 logs. So the next phase of the protective triad is inactivation, pathogen inactivation. So what current methods are used to inactivate pathogens in blood products? So one method is damage to nucleic acids of infectious diseases. So if you've ever eaten figs or celery or citrus fruits, then you've ingested some psoralen at very small levels. Psoralen is a compound that, obviously a natural product that intercalates DNA. Amotocillin, which is the basis of the intercept pathogen inactivation system, is a synthetic version with the addition of this amino ether. And this is currently this is the system, the only system that's FDA approved in the U.S. And it's the current system by which our blood bank pathogen inactivates all the platelets that are used for investigators who do research in the clinical center. So I just have a cartoon that shows how this works. Amotocillin is a DNA intercalator. We develop permanent cross-linking after adding ultraviolet A illumination, which blocks replication, induces apoptosis. And the system in our lab, in our department, looks like this. The platelets are collected in a bag mixed with amotocillin. They're then laid flat on this instrument for maximal penetration. They're illuminated with UVA and activated. Then have this step we move the platelets through a compound adsorption device that removes most of the amotocillin, and then the platelets are then moved for final storage. So how does this system perform? Well, with enveloped viruses such as HIV, Hep B, and hepatitis C, we're seeing a 4 to almost greater than a 6 log reduction. Non-enveloped viruses like adenovirus are about the same. Parvovirus and hepatitis A virus have a slightly smaller log reduction. Pathogen reduction of bacteria is decreasing gram-positives and most clinically relevant gram-positives and gram-negatives by over 7 log. Spirochetes and protozoa are also inactivated at over 5 log. So the system is being used in over 100 countries, over 100 centers in 20 countries. It's actually been used in Europe since 2006, but just FDA approved in 2014. And the NIH Blood Bank was the first adopter of this technology in pathogen inactivating our platelets in the United States. And just recently, one of the major blood organizations that collects about 30% of the U.S. blood supply has agreed to pathogen inactivate all their platelets with this system, starting in, may have started early 2018. So there's another system called the Mirasol system that is not FDA approved, but uses a slightly different technology. It uses riboflavin, which is vitamin B2, that also binds to nucleic acids and is also activated by ultraviolet radiation. Interestingly, there was a recent study using Mirasol, this Mirasol system using riboflavin in Ghana. Ghana and many countries in Africa, you transfuse whole blood. And the parasitemia of malaria is, on average, in Ghana, around 50% of blood donors. In many other countries, is very high, 20 to up to 50%. In this study, it's using this Mirasol system, it significantly reduced transfusion-transmitted malaria. So what are the advantages of pathogen inactivation or pathogen reduction? It inactivates most clinically relevant viruses, inactivates almost all clinically relevant gram-positives and gram-negatives, as well as other organisms. And I should star this, also can preemptively probably activate all new, you don't have to guess, it will inactivate all new and emerging agents, even agents that we don't know are circulating yet. And there are some other positive components that we also are seeing fewer platelet transfusion reactions. This is only reported in 1 or 2 studies so far. So there still are some major limitations. It's currently only licensed for use in platelets and plasma, and still most of our transfusions are red cell transfusions. So it's only a limited percentage. There is some decreased platelet yield, although newer studies and changes in the system have shown to improve that yield. There is insufficient kill of some agents, as I showed, not as significant a log reduction or a lower log reduction with Hep A and Parvo. It does not activate prions like Creutzfeldt-Jakob disease. There's theoretical toxicity, although for both of these systems that I mentioned, the toxicity is very low. And the question always comes up of cost. Why haven't you done this already? Why did Europe start this in 2006 and the US has been such a slow adopter? And the answer is usually cost. That's usually also the first question. How much is this going to cost? So there's a significant cost in implementing the system, but it's been interesting in some studies, in recent studies that have done cost effectiveness analyses, they've actually shown that the offsets to the that there are major offsets to the costs, and there can potentially be some cost savings. So, for instance, currently we have to do bacterial testing of platelets that are stored at room temperature. Pathogen inactivation eliminates that. We no longer have to irradiate products. It could potentially extend platelet shelf lives. Currently, when we collect platelets, we can only use platelets for 5 days. So that makes the supplier logistics very difficult. It would eliminate the use of of some or many of the screening assays, and as I mentioned, would preemptively inactivate new agents or even unknown agents, and could reduce donor exclusions based on geography, which could potentially increase the donor pool or reduce exclusions. So McCullough had published this transfusion in 2015, and through a number of these cost reduction offsets that I mentioned, they were actually projecting a cost benefit per unit of over $142. So alas, I'm losing my voice. We're at the end of the talk. I had to pass on some wisdom donated by Harvey Alter anonymously. But blood transfusions is a difficult endeavor. I'd like to give acknowledgments to Dr. Harvey Alter. This is Dr. Alter in his youth. He still today looks pretty much the same. He, like Tony Fauci, has aged very well. He's been a mentor for many years. He's the eliminator of post-transfusion hepatitis and holds a record as being chief of infectious diseases for over 100 years. I also want to thank patients and research participants, our collaborators, members of my section, our department, and the NIH Clinical Center. And thank you.
Thank you for very, very enlightening and very detailed presentation. We have time for a few questions, and we can start here.
I noticed on one of your early slides that it looked like about roughly 50% of the blood that's donated is actually used for transfusions. Is the rest of it just thrown away, or is it used for research, or what's the story there?
Yeah, so one of the issues, good point, is we do in our field have a lot of wastage. Some products can be processed and frozen, but for instance, for emergency situations, for trauma situations, often you have to have a lot of extra product on hand. Product has a shelf life. Luckily, red cells last 120 days, although there's evidence mounting that it should be used much earlier than that. But platelets, for instance, as a good example, platelets are hard to collect. We have a limited supply, and we have to store them at room temperature, which means we can only keep them for so long. So, in the blood community, people have gotten very excited about strategies to extend the shelf life of platelets from 5 to 7 days. So what kind of a valuable resource this is when you're trying to extend 2 days. Yeah, so I think the bottom line, unfortunately, there's a lot of wastage because of shelf life and also for kind of surge capacity.
So the answer to the question is that is those units being discarded?
They're being discarded.
Discarded.
Yeah.
Are you saying 50% of blood is discarded? I don't think that's right.
Let's see.
That's,
I know it's right because I think it's your slide.
no. I don't want to leave that impression because I don't think that's right. But anyway,
it was about 40. This is actually from I think the 2011 blood survey that Health and did I pass it? That Health and Human Services did. So So this comes from the 2013 ABB blood survey report. So yeah, this comes from their data. This is what they're reporting. They actually don't in this report comment on wastage.
Yeah. So
or reasons for this, but these are the numbers that ABB is reporting.
okay. Sorry. Well, I just want one good job, really good job, and secondly, thank you for all the acknowledgments. But I know from our prior discussions that you meant to also acknowledge Valeria DeGiorgi, who helped to develop the chip. Really did a very important part, and you've mentioned her so many times. I think you just failed to mention that.
Valeria DeGiorgi, who's sitting right here, the beautiful woman in the purple dress.
So could you tell us what's going on in the area of artificial blood, or because of all the problems with pathogens and everything, so is anything developed with the blood substitutes?
To tell you honestly, I don't. I hate to say that I've given up on blood substitutes. It's very interesting, but I'm not an expert in that particular area and haven't been following the literature. But my understanding is it's still very far off, unfortunately. And particularly, I think the military has led these efforts for the field. But I can't even tell you how many years off. Is anyone in here, Harvey might know this better than anyone else, where we are in developing synthetic blood substitutes.
Yes, we are nowhere. They've all failed. Hemoglobin, membranes. Some of them can work for a day, but I don't think anybody's pursuing it right now.
Since we just heard about vaccines, I wanted to ask if, let's say you knew the potential donor recipient was successfully vaccinated against one of those agents that were in the donated blood, could you then use, let's say, lower quality donated blood for transfusion into a recipient that somehow had the immune capability of accepting it, or possibly the logistics of keeping track of all of that might make it not feasible?
Mm-hmm. Yeah, you answered your own question with that second point. I think it's more of a logistical issue, but you also couldn't guarantee 100%. But it's an interesting point because in an emergency scenario where you had no other product except for the infected product, and that patient was going to die unless you used that infected product, that actually has come up on an individual basis where no other product was available, no other say there's only one matched product. Those are the only products you could use. And then you'd have to calculate in a committee, usually in some kind of a committee, you'd have to weigh the risk benefit of transfusing that unit. So that I can't quote specifically what the instance is, but I know that that scenario has come up and that has happened, but only be extremely rare and only in an emergency scenario.
I have a question. I work at Inova Fairfax Hospital in Northern Virginia, and at the Inova Blood Donor Center in Sterling, Virginia, they supply like 8 area hospitals, Sibley and DC. And we've been using the Sorlin treatment now for a while. I'm a little blood banker in the lab, and we don't have to use CMV negative. The Sorlin takes care of that. I understand that. But could you touch on how it inactivates lymphocytes to prevent graft versus host disease and substitution of irradiated blood? Because we don't irradiate it, we can use the Sorlin for irradiated requirements as well.
Yeah, but very much in the same way as pathogens. So it's by damaging DNA, amotosalen intercalating DNA of lymphocytes, and UV inactivation. and activating apoptosis. But I would caution that because I can't quote the data on replacement of irradiation with, even though the manufacturer has said that, I would want to talk with you after and kind of dig more into the data.
Do you do that at NIH? Replace it? Or do you still irradiate blood when it's required? I mean platelets. So therefore you don't substitute sorrelin-treated platelets for irradiation? You do not? You irradiate platelets when you have to?
No, we
You do irradiate the platelets?
We still irradiate, don't we?
No, not platelets.
No, not
The
platelets, right.
sorrelin?
Not platelets. Not
Okay.
platelets, yeah. It's replaced irradiation of platelets, correct.
Well, where we get another question, I wonder what happened to the donors when you find an infectious, and always is a question for us. You find an HIV, HBV, HCV, serious infection. How does the donor is ever informed, or how is the donor perhaps eliminated from further donations as well as information?
Yeah, no, that's a good question and close to my heart because I either see or talk to or communicate in some way with all of those positive donors. Actually, just on Christmas Eve, I was calling someone back who had received a letter and who had been indefinitely deferred due to positive tests. So spent an hour counseling. So there is a process in place for notification. In some cases, we can't do everything in our system. In some cases, we retest and do confirmatory testing. And in other cases, like the particular case with this donor, I had to counsel and then refer to their primary care doctor or to outside of our system because the confirmatory testing and counseling was really beyond our capacity or the capacity of any.
But basically, they receive a letter informing them that they tested positive and
that's
will be
right.
communicated.
That's
Yeah.
right. That's right.
Other questions? Yeah, please.
How much of the sorrelin derivative do you actually transfuse into people?
The concentration?
Well, enough to damage the recipient's nucleic acid.
I'd have to look that up for you. I don't know the exact concentration that we're using.
I can't give you an exact concentration, but the amount of sorrelin is very small, and then the product goes through an absorption pack. So it removes almost all the residual sorrelin before it gets into the final pack. So the risk is no higher than background sorrelins that we eat or have in the air.
Thank you for your talk. I'm curious about plasma donation. I know plasma has been implicated in the early spread of HIV to hemophiliacs because of factor VIII. So what are the screening processes for plasma? Because they're still paid. And how much does it cost?
Yeah, so because of time constraints, there are probably 20 slides on the whole all the processes involved. The industrial processes. So plasma is a business. It's an industrial complex, and they are using solvent detergent methods and pasteurization and multiple pathways and testing and screening. I'm seeing the slide, but I can't recall the number. And unfortunately, I don't have it in my background slides. But there hasn't been a transfusion-transmitted infection, HIV, or any other transfusion-transmitted bug from plasma 10 or 20 years. So the system has been proven to be very, very safe. If I recall, at NIH, I'm a research scientist. I'm not working in this industry, so I don't get as much contact with how this as a company works and who's doing what. I have a general sense of what technology they're using, but they may or may not also be using pathogen inactivation that I've presented. But because its cost is not an issue with them because they are charging quite a bit for the product and paying the donor. That's true. I'm saying that donors are higher risk, but it's been accepted and licensed and proven through data for many, many years that even with this higher potential baseline risk, that there have been no transmissions.
With some of the novel techniques of concentrating DNA as well as RNAs, is some of that could be implemented for testing?
To improve sensitivity? Yeah. So Valeria in my lab is actually using some of those techniques. Nothing's been validated yet. Actually, we were using it with Zika. There were some issues in testing and sensitivities of testing Zika blood because Zika binds to red cells. So actually the licensed tests are for plasma, but the better test would have been Zika bound to red cells, but we are where we are. But in particular, she was using it in Zika urine. So there's some issues and some issues with sensitivity. It may have been due to degradation. We haven't been able to sort that out at a recent Zika conference. I don't think anyone has been able to sort that out yet. We're also having that problem with some other arboviruses, not flaviviruses, but alpha viruses like chikungunya. So the short answer is yes, people are trying it. The methods, we're not sure what is working. It hasn't been validated yet, but it's a good idea. I think it's a good concept to concentrate. Some people would advocate using more volume, so going from 200 microliters to 500 microliters. The data on that are not certain. I think we've tried that, and it hasn't bared out for us, right? But yeah, the using different methods of filtration is one of our interests, and there are plenty of other groups that are also using that as well.
Other questions? Well, certainly, Dr. Allison, thank you very much. Very, very
really my
provocative.
pleasure. Thank you so much.
And you have personal questions, you can come up.